I'm ready, Sanket.
Sure, ma'am. We'll start.
Yeah.
Yeah.
You want to say something or shall I begin?
Yeah, sure, ma'am. We'll start, and obviously, I have discussed this topic, but I wanted from best, so it is now on you. And madam recently had a talk at Epicon also on the same topic, but we are, I think, covering both the aspect of hypoglycemia in diabetic. I think that still you will feel easy once you are done with training. But when you get a hypoglycemia without diabetes, that's a case of the day. So I think we will learn how to approach at this. That's more important, and then the other things will come out. So with this intro, ma'am, I think we should start.
Yeah.
Sure.
Thank you, Sanket. Yeah.
Sure.
And always a pleasure to read for these classes and tell you what I know. So like Sanket was telling, in this class, we will cover both aspects of hypoglycemia. One is, of course, diabetic hypoglycemia, which forms 95% of the hypoglycemia you'll ever see in your life. Probably I should have put it as 99 because that's how common it is. It's a very important topic. It's a very practical topic and a must-know topic because though the non-diabetic hypoglycemia may be rare, interesting, and challenging, the point is that the diabetic hypoglycemia is something that we will deal with on a day-to-day basis. And many times we make very common mistakes in dealing with diabetes and hypoglycemia also. And that is why I thought we will cover the diabetic hypoglycemia first, which is what most of you know, but we will highlight some aspects which are not commonly emphasized. And then we will go to the non-diabetic hypoglycemia, which is what all postgraduates look forward to. So I'm keeping the more important topic as a second one, because that's what you would find it rare, you would find it interesting, and you would find it challenging. And it will be once in a blue moon case, and then you will make a diagnosis and feel very thrilled for the next 1 week. So let's go on with the topic. Just to give a framework, I'm not going to talk more about the pathophysiology or the theory part of hypoglycemia. This will be a clinical approach to hypoglycemia, but just that we recollect, we all know that once you get a hypoglycemia, you get the counter-regulatory hormones about which we all know. And I think you have to mute others, Sanket.
Yes, ma'am, it's done.
Yeah, done. Okay. So we know that the counter-regulatory hormones are equally important in the manifestation of hypoglycemia and in the response of the human body to hypoglycemia. So we know that the glucagon comes in first, and then the catecholamines, then the cortisol and the growth hormone are like elephants. They come in a little later, they walk a little slowly. The catecholamine is the rabbit that runs fast, and you get the autonomic symptoms of hypoglycemia, which are dependent on the sympathetic system. That's what gives you the typical features of hypoglycemia. And of course, if you do not recognize and treat hypoglycemia at that level, then you start getting the neuroglycopenic symptoms. And I have written as less than 50, but I will explain to you as we go by what this number means. Okay. So let's talk about diabetic hypoglycemia, which is forming 95% of the practice of hypoglycemia that we see. So let's go into that first. Now, whenever we have hypoglycemia in diabetics, we usually have these three things, right? Missed meal, unusual exercise, overdose of insulin and sulfonylureas. These are the usual suspects. And this, I think all of us know and all of us must ask for. Because many times when patients wait for us in the OPD, they are scared to even go for a coffee or tea because they feel that the doctor will call them next. And many times they do go into hypoglycemia on that particular day when they're coming to see us. And of course, unusual exercise, especially in over enthusiastic people who want to, run a lot, or especially when you first make a diagnosis and tell them you have to exercise, this will happen. Overdose of sulfonylurea or insulin is either because of, some kind of mismatch with the doses or something like that. These are the three things that are important to us. These are the usual suspects, but let's look a little beyond them and look at other causes of hypoglycemia in a diabetic. We're still sticking on to the diabetic patients. Now, all the case scenarios that I'll be talking about just after this, I want you all to answer, okay? Not to anybody, but to yourself, so that you give yourself an answer and then listen to my answer, so that it's an informal test for yourself and it is fun, right? So all the cases that I'm giving, the answer will come up only when I click. So I want you all to attempt it before I say something. So let's look at case number 1. So he's a diabetic hypertensive of 15 years duration, and he's on premixed insulin, glimepiride, metformin for his diabetes. Of late, is developing hypoglycemia pre-lunch and post-dinner, though he hasn't changed his insulin dose or his diet. So he's a long-term diabetic and hypertensive. He's on all these things, okay? And he's getting a hypoglycemia pre-lunch and post-dinner, but he hasn't changed. If you question him, did you change your insulin? Did you change your diet? He says nothing is there, okay? So what are your possibilities? I will give you 5 seconds to make your answer and then go to my answer. The most important thing that we would consider in such a patient is the worsening renal function test, okay? Because he's a long-term diabetic and hypertensive, one of the things that is often overlooked is looking for the deteriorating renal function, and we will explain why. Now, we all know that whenever you have CKD and hypoglycemia, if you look at this chart, you will find that not only hypoglycemia is more common in CKD, more common in this combination of diabetes and CKD, plus the more severe hypoglycemias also occur in CKDs. Okay, so this is very, very important to remember that if you have a patient who's done nothing wrong, okay, and you've ruled out your usual suspects, you're still getting a hypoglycemia, one of the most important things to do is to do an RFT. Now, why is there this hypoglycemia and renal dysfunction? Because both the endogenous and the exogenous insulins are excreted by the kidney. And so there is a prolongation of the duration of action of all of this. And one of my professors taught me about 30 years ago that a regular insulin will become an intermediate acting insulin. Remember that when you're giving a regular insulin, it's probably not going to work for 6 hours. It's going to work for 8 to 12. So sometimes you can even manage with 2 regular insulins per day in a person with a deteriorating renal function, especially when you have a CKD5, things like that, because the excretion of insulin through the kidney is not there. So it tends to act much longer. The second important thing is that the renal gluconeogenesis, neoglucogenesis, that we don't really, most of us think the diabetic metabolism is usually from the liver. The liver is the main hero of the place, but the kidney has a significant contribution to the production of glucose. It contributes to 25% of the neoglucogenesis that comes in a little later as a response to hypoglycemia. And remember, this is activated by the sympathetic nervous system. The sympathetic nervous system stimulates the kidney to produce glucose. So if you have a problem with the sympathetic nervous system, or you have a problem with a reduced renal mass or a dysfunctioning kidney, you will not get the contribution of blood sugar from the kidney, and that's what will drive the person into hypoglycemia. The third important thing is that the drugs excreted through the kidney, like we said, insulin, the sulfonylureas and so many other drugs. All of them excreted through the kidney will have an accumulation, a stacking up, and they can all contribute to hypoglycemia. That's why we need to remember to adjust the doses of all the drugs when we have a person with a renal disease with hypoglycemia and diabetes. I don't want you all to walk away thinking that CKD always causes hypoglycemia. It can cause hyperglycemia also. So if you look at this chart, you can see hypoglycemia on one side and hyperglycemia on the other side. In fact, hyperglycemia is also a feature of chronic kidney disease because of, if you go down this chart, you will find that because of the increased insulin resistance that happens because of the secondary hyperparathyroidism or the low vitamin D and decreased insulin production, etc. Everything is causing hyperglycemia here, right? On the other hand, and uremic toxins, they are also causing increased insulin resistance. In fact, post-dialysis, many people's sugar control improves because you remove the uremic toxins. So remember that it can cause hyperglycemia also. On the other side, because you're not degrading the insulin, not only excretion, degradation of insulin happens in the kidney that you're not doing. You got a deficient catecholamine release. Remember, I told you the catecholamines are the ones that are going to cause renal gluconeogenesis. So if there's a decreased catecholamine release, then you don't get this contribution. And there's a decreased insulin clearance. So there's a decreased insulin degradation and a clearance, and you're not getting the glucose that you get from the kidney, all of them. And of course, uremic malnutrition. The person is not going to eat much, so you get hypoglycemia. So if you look at this, actually, the hypoglycemia is a feature of later aspects of kidney disease more than CKD3, whereas hyperglycemia can occur in the beginning. So if you have a person who's done nothing wrong, but you have a very high sugar or a very low sugar, one of the things that you should always ask for is a creatinine. The one crucial investigation, I work in a place where people cannot afford much money. So when they ask me, I can do only blood sugar, what else can I do? Then I put one tick, and that is the creatinine, because that's a second crucial investigation in diabetes, because not only it contributes to, which drug you choose. I mean, can you give some drugs? Can you not give some drugs, etc. Also, it tells you that the A1C, the hemoglobin A1C that you're doing may not be reliable with your creatinine going up. So your control is also become, difficult to interpret, and your drugs that you use will also become difficult. So if you have a diabetic who cannot afford many investigations, just put one extra tick, and that is for the creatinine. And that's a chart that I think you all know, about different kinds of drugs and how to what GFR can they be given. That's a chart that you can access anywhere. But suffice it to say that we have to adjust the dose of insulin, think of the extension of duration of insulin. Remember, if you give 3 regular insulins, it may stack up, especially in the later stages. And in the sulfonylureas, the safer sulfonylureas are glipizide and gliclazide, and also glimepiride to some extent. But as you can see here, the glibenclamide is a no-no. Over the age of 60, 65, especially if you have a renal dysfunction, a glibenclamide causes much more hypoglycemia. And the gliptins, especially linagliptin, is probably safe. SGLT2 inhibitors can be given up to 30. The metformin, the 50% rule. Less than 50, you give 50% of the dose. Less than 30, don't continue, because of the tendency to cause acidosis and lactic acidosis is a problem. So this chart you all know, and you know that once a person goes into CKD and hypoglycemia, then you know that you can't use many drugs. Many of them are off the charts for you, and you should probably stick on to only some drugs which are safe, which I have named here. And these are the drugs that you can give. And the duration of action of insulin is something that you should think of. Just a quick word regarding the sulfonylureas. Most people will say, give the gliclazide. The gliclazide is a costlier drug than glipizide. In our practice, we use a lot of glipizide, which is actually 2.5 milligrams, small dose, not very expensive, can be given in patients with CKD, and up to a 30 GFR we do give. And we have to warn them about hypoglycemia, but it's a simple drug that can be given. Remember that though we say that the duration of action of the regular insulins will be prolonged, sometimes you may have to not give a bolus at all, but give only a basal. So again, many people think if it's basal, you have to give an analog. You don't have to. I have seen many of my colleagues using an NPH, insulotard can be given, and that is quite good. It will take care of most of the hyperglycemia, because though it's got a small peak, it will not matter in a CKD. So if you need to give a basal, if your fasting insulin is high, then you can give an insulotard or an NPH in the night, and then give a few basals or a few, a small dose of a gliptin, etc. in the afternoon, then you should be fine. For the rest of the things, please follow the chart that I had put up, which is accessible to everybody, right? So the most important lesson we learn is that if you have a person with diabetes with hypoglycemia, think of a renal dysfunction as one important possibility. Let's go into the next problem. 56-year-old diabetic of 15 years comes with repeated hypos. Of late, she feels tired on minimal exertion, gained a lot of weight. Diabetic medication has remained the same. No changes in this thing. So she's tired, gained a lot of weight. Lady, 15 years. So what do you think of? It's hypothyroidism. So the next tick that I would ask, especially if somebody has gained a lot of weight and is getting hypoglycemia, is that whether they have a hypothyroidism, and I would tick a TSH there. Another simple problem, 56-year-old alcoholic is diagnosed with disseminated TB, is emaciated, that's his BP, which is low, sugar is low, sodium is low, potassium is high. That's a giveaway. That's nothing difficult about it. It's an Addison's because of tuberculosis. Okay. So that's an easy problem, right? So you got an alcoholic, he's got TB causing TB adrenalitis, and then you got the typical hyponatremia, hyperkalemia, hypotension, and hypoglycemia. That is Addison's. Okay, let's go to another interesting problem. 40-year-old type 1 diabetes troubled with burning sensation of feet and feels giddy on standing. He's unable to eat because of nausea after meal. He vomits once in a while and feels giddy by noon. At that time, somebody took his sugar and it was 40. So read that problem again. It's a 40-year-old type 1 diabetic, burning in the feet, giddy on standing, unable to eat due to fullness, vomits. So putting everything together, and there is a hypoglycemia there. What is the diagnosis? I think you would have guessed it again. That's a gastroparesis, right? So he's got a peripheral neuropathy. You can look at him. He's got a peripheral neuropathy. He's been diabetic for so long. He's getting an orthostatic hypotension. He's getting a gastroparesis. That's why he feels full and he's nauseous and he tends to vomit. And then you got a low sugar. That's because there's a gastroparesis. So the food is not getting out of his stomach at all to get absorbed. So many times I've had these are people who come with what we call as brittle diabetes. Suddenly they have a high sugar, then they have a low sugar and hypoglycemia, and then it's very tough to treat. So we have to educate these people. We have to tell them that they have to, especially in the context of an autonomic neuropathy, you have a gastroparesis. There's no way you're going to prove it, right? It's a intelligent guesswork based on the symptoms. You can give a domperidone. I found it very effective. So I used to give 10 milligrams domperidone 3 times a day, and then the stomach would probably move, and small meals many times the person takes, then this gastroparesis can be taken care of and the hypoglycemia can be avoided. So remember that when you have a person with peripheral neuropathy, in that context, you have an autonomic neuropathy, and then this patient is having a hypoglycemia. Remember that gastroparesis can be a very, very important cause which you should address and treat to avoid that hypoglycemia. Okay, right. Let's look at this again. You have this patient with hypoglycemia. The RFT, I told you that's a #1 investigation, normal. Now you look for hypothyroidism, Addison's, gastroparesis, all are negative. Okay, so we finished the first 4 causes, right? All are negative. Now what? Okay, let's look at what would you think of if a person has hypoglycemia without any change in anything, and he's not done anything wrong. All these, what would you think of? That's when you should look at people taking insulin. This doesn't apply to others. People taking insulin, you have to think whether they have any problem with their insulin injection, and you can have things like this, lipoatrophy, lipohypertrophy, all can happen. And because of that, they may have areas from where insulin is either absorbed too much or not absorbed. So this is a cause of hyperglycemia and hypoglycemia. Both are possible, but people who take insulin, who have got a difficult to control diabetes, and they have either a hypo or a hyper, have to inspect the area. Many times nobody asks the person how he takes insulin. This is the worst thing that happens in this country is there's no education given to a patient. Patient is given one insulin and one syringe and say, do what you want. I've had very strange people take insulin on their somewhere near the Achilles tendon. All kinds of crazy things go on here. And many times people do not walk like that on the side without lifting up the subcutaneous tissue at all. Nobody takes that 5 minutes to explain to the patient that he should change the site of insulin injection. So wherever it is convenient, right-handed person keeps on injecting on the right side. It should be. And if you just strip the person and see where they are taking insulin, you will discover trophy, both cause swings in blood sugar. I've had hyperglycemia patients thank me so much after you simply told them this and they became under control. And people going into hypoglycemia also change the site and then you would get a much better result. So remember, this is the important cause in people taking insulin. The other thing is that 40 units and 100 units insulin, the 40 unit syringe with the 100 unit insulin, things like that. Syringe or this thing. So many times you have to ask them. A new site of insulin injection may lead to much more better absorption. Better absorption. And walking immediately after the injection also can cause a problem. That when a person is on insulin and you have a hypoglycemia, you have to check the insulin as one of the factors which is probably causing hypoglycemia. This is from Davidson, okay, but if you look at the causes that you have, you say the delayed, which I'll talk to you later, errors in oral antidiabetic agents, poorly designed insulin regimen, and paresis, malabsorption, which I didn't talk about, and then your Addison, which is not mentioned here, factitious, I talked about. One word about so when the young type 1 diabetic is breastfeeding, then you get a lower blood sugar and better to have a snack before and after the breastfeeding. Watch hypo, right? Okay, now look at the second aspect of it. When is the person getting hypoglycemia? These are the risk factors that we, but when is the person getting hypoglycemia when they are diabetic? So 60-year-old man develops hunger and he these things, okay, in form and glimepiride, what will you advise him? Now, many things like this can be actually taught to. So you teach the patient that this 20 is what causing your pre-lunch hypoglycemia. And this is what you should be at. You tend to take out the insulin first when you're getting a hypoglycemia. So depending on the timing of, you can adjust the prescription and ask him to maybe take a mid-morning snack or come down this 20 units, etc. That will avoid the hypoglycemia. So check sugar and adjust the insulin. Now look at this problem. 60-year-old lady, fasting is 230, PP is 140. 15. What would you like to ask her? Okay, before you go and hike up that dose of insulin, always ask for a not hypoglycemia with a rebound, because many times patients don't got up in the night, they had a glass of water, they felt hungry, etc. But remember, it could be a rebound, and the next time they get up like that and feel hungry, ask them to do this thing. And if you go and increase this insulin, you will get more problem, because the patient will go into more hypoglycemia in the night, and this fasting sugar will actually go up, the homeostatic phenomenon. So whenever you have a high fasting but an okay, then please remember that your problem may not be is going in for a nocturnal hypoglycemia. Remember this, that's important. So ask the patient to keep to write and come. Now, this is a very simple, it's not even a postgraduate level, it's an undergraduate level, 2 scenarios that I put up. So 45-year-old lady detected to be diabetic 3 months ago on glibenclamide. She goes to a wedding and then she doesn't eat on time and she gets a sugar of 35. She's sweating and has tremors. 75-year-old man, 20 years, brought to casualty, same RBS, doesn't wake up. Okay. Now, what's the difference? The RBS is the same, but this person started sweating. The autonomic nervous system is still intact. So, because it's a younger person and only 3 months into diabetes, this person is old, longer duration of diabetes. Same this thing, he went into a neuroglycopenia because the autonomic nervous system is probably not active in this person. So the recognition, if you look at the clinical features, you know these things. I'm not going to explain these to you, but the autonomic nervous system being intact is what gives you all these symptoms. Otherwise, you would go into one of the neuroglycopenic things. One thing that is underemphasized is the headache. Many of the normal people also get a headache whenever they have hypoglycemia and they feel much better on eating. It often happens in a diabetic also. So if they get a headache and then they feel better on eating, probably that's hypoglycemia. That is a very underemphasized symptom of hypoglycemia. Tiredness, of course, everybody knows. Now, I want you to look at 2 problems. Diabetic patient is brought with convulsions. His sugar is 100 and he's unconscious. What's the diagnosis? The second one, diabetic patient comes with right hemiparesis. Resident starts a DNS drip and his hemiplegia recovers. What is the diagnosis? Okay. Now, look at these 2 problems. You are thinking of neuroglycopenia, right? So, this is probably a neuroglycopenia, right? This hypoglycemia is one of the exceptions to the rule that a metabolic cause usually does not cause a focal deficit. Generally, we say, when we approach a coma, we say if there's a focal neurological deficit, it's probably anatomical, right? Whereas hypoglycemia is one major exception to that rule, that you can get a hemiplegia in a hypoglycemia, and this person like this, many times one intern will start one drip and the patient's hemiplegia will go off. You are thinking, oh, is it a TIA? But if you have done a sugar at this time, it might have been low. I'm not given that in this problem. But look at this. The blood sugar is 100. He's unconscious. Now, please don't call this hypoglycemia. There's some other reason. So, when does neuroglycopenia occur? Though we gave a number as 50, usually occurs less than 30. So, it's actually a very low level of blood sugar that can cause any of these problems. So, don't go and label some other neurological problems as because of hypoglycemia, because it usually doesn't happen that way. Remember, earlier I gave you as 50, now I gave you as 30. Some may question me why am I changing the numbers? That I will explain to you a little down the line. Okay, so 70-year-old diabetic was waiting. This is a true story. Government hospital for hours to see a doctor as the queue was long. At noon, he became agitated, slapped the hospital attendant, and security personnel caught him, and the son said the father was never a violent person. So what did the sister do? She solved the case. This person had hypoglycemia. So remember, hypoglycemia can present with a lot of neurological complications like convulsions, coma, hemiplegia, confusion, agitation, etc. So remember that whenever you get an unexplained neurological thing, one of the first things that you do is to rule out a hypoglycemia. Okay, let's go to something quite interesting. 16-year-old girl, type 1 diabetes, very careful, okay, because she's been educated. She's very careful about her diet. Of late, she wakes up very hungry in the morning. Mother says she wants to eat as soon as she gets up. One night, she's found unconscious. And the hospital where she's admitted finds her blood glucose to be 30. She's given dextrose and wakes up. Now, what has happened to her? She's a very, very careful person. Okay, she's been always controlling her sugars and of late becoming very hungry, eating it up. Okay, but suddenly she has become unconscious. So, what has happened now? This is called impaired awareness of hypoglycemia. It's also called hypoglycemia-associated autonomic dysfunction or HAF. And this is described by Dr. Kreyer, who has written this chapter in Harrison. This is a functional failure of the autonomic system because of repeated hypoglycemia leading to neuroglycopenia. So that's important. So this girl was getting up many times, right? She was getting up with hypoglycemia, eating it eating to avoid the hypoglycemia, etc. So repeated episodes of hypoglycemia, every time the autonomic system responds, the set point will keep coming down and down. So first it may respond at 50. Later on it gets used to 50, it responds only at 45. Then it responds only at 40 and then goes into neuroglycopenia. So this is a functional disorder of the autonomic system, and it is now called as impaired awareness of hypoglycemia, which is very, very dangerous because these patients can come with severe hypoglycemia. Now look at this. How do you manage this patient? I want you to look at all these answers and in your mind answer why. You want to adjust your target to be 7%. You want to decrease her insulin dose at night. Ask her to have a post-supper snack. Avoid hypoglycemia for a month. Warn her she has autonomic dysfunction and she'll always have unawareness in the future. Now look at which of these things is right? I will explain this. Her target is not 7. She's a young girl. Her target is 6. Ask her to decrease the insulin dose at night. Fair enough. You can. Okay. But it won't solve her problem. Ask her to have a post-supper snack. Correct. That's correct. But it won't solve her problem. What will solve her problem is avoiding hypoglycemia for a month, because this is a functional disorder of the autonomic system. If you want to resensitize the autonomic system, if you want to get it back to respond to hypoglycemia, you have to avoid hypoglycemia for a month. If you avoid for 4 to 6 weeks, then the autonomic system will come back to normal and then she will start having autonomic symptoms. That is why this is the most important, and this is wrong. She has autonomic systems and always be unawareness. That is wrong. This is a functional disorder. So this is common in type 1 diabetics, and please remember all your type 1 diabetics that repeated hypoglycemia is not at all a good thing. Never a good thing, because it keeps on changing your set point and keeps on knocking out the responsiveness of the autonomic nervous system, and patients tend to come with neuroglycopenia, which is the most dangerous part, and you have to avoid autonomic hypoglycemia for 2 to 4 weeks to restore, because it's a functional disorder of the autonomic system, most commonly seen in type 1 diabetics. Okay, look at this one. 80-year-old man brought with altered sensorium. He's diabetic for 35 years. He's on insulin and gliptins for that. Sugar is 40, resuscitated with dextrose, and those are his sugars. Fasting is 100, PP is 140, A1C is 6, creatinine is 2.5. He has difficulty in feeling the ground and had a fall last year. What advice would you give him? Now, this man is 80 years old. These are his sugars, and that is his creatinine. Obviously, he is going into hypoglycemia. There is a renal dysfunction. There's an over-controlled sugar. Everything about him is over-controlled, right? And to add to the confusion, he's got difficulty in feeling the ground. That means he's got peripheral neuropathy, may have autonomic neuropathy, and you're always worried that he's going to not respond to hypoglycemia with autonomic symptoms at all. So this person has a permanent autonomic dysfunction. Unlike the 16-year-old girl who had a functional autonomic dysfunction, this is permanent. So this person, you don't need this target. You don't need, in an 80-year-old man, your target is not 6. Your target is 7.5, right? As you age, you raise your A1C target. You don't keep it so low, especially with that creatinine, which is going to add to hypoglycemia. Never do this. So avoid hypo. Hypo is more dangerous in this man than hyper. So what are the risk factors for severe hypoglycemia? Like we said, strict glycemic control. Impaired awareness of hypoglycemia will lead to more hypoglycemia. Hypoglycemia begets hypoglycemia. Very young or very old. Increasing duration. That's why I said the longer the duration, the more the autonomic dysfunction and the more the hypoglycemia that you can go to. The sleep, I'll talk to you in a bit. And the C-peptide negativity, complete insulin deficiency, which happens in type 1 diabetics, is a very important cause of hypoglycemia. History of previous severe hypoglycemia is always bad. Renal impairment, as we said. And this is a rare condition. A genetic angiotensin converting enzyme genotype can predispose to severe hypoglycemia. But look at the things that are very important to you. The renal dysfunction is very important to you. The unawareness is very important to you. And the old people, they can all get hypoglycemia. Sleep and hypoglycemia. especially dangerous in the elderly. If you have an old person who's getting into hypoglycemia, especially in the night, that's not at all a good thing. So we should avoid hypoglycemia in such people. Remember, very underemphasized fact that hypoglycemia actually can recover on its own. Those who have hypoglycemia at night, many times, like I told you, patients will tell you that they got up, ate a glass of water, etc. They've done a sugar at that time. It may be borderline 65, 70, like that. That's also hypo. Especially if they have sympathetic symptoms in younger people, please look for this and don't think that they have to eat something to recover. They may recover without it. Sleep disturbance can occur because of hypoglycemia, because of they are forever hungry or something like that. And sleep deprivation with hypoglycemia plus cognitive dysfunction, all of them lead to more problems in diabetics. So sleep, ensuring a good sleep is important for diabetes, for control and to avoid hypoglycemia. For both, it's important, right? Okay, now look at this. 50-year-old clerk is brought with a sugar value which is very high. She are feeling tired. Of course, 50% of diabetics don't know that they are diabetic. Started on Mixtard, asked to take small meals. She followed, but she felt tremors and palpitation pre-lunch, and she thought she's going into hypo. Sugar was 250. So what's the diagnosis? How do we manage her? Now, the sugar of 250 is from the 540, it came down to 250. So at 250, she's getting sympathetic symptoms. This is not a hypoglycemia by biochemistry. It's not a hypoglycemia, but you can get hypoglycemic symptoms when you fall from a high value to a low value. And this is what we call as the concept of the set point. The point at which the body responds to hypoglycemia is your set point. So your set point for a person who is from 540 to 250 itself, they may start feeling hypo. And many times you will find patients saying, oh, I got hypo, so I ate up. So you ate up and sugar never came under control. Now, please remember to tell your patients that if you feel like that, just check your sugar and confirm that it is hypoglycemia, then eat. Doesn't matter, okay? But otherwise, in the first few weeks of controlling a high sugar, you may get hypoglycemia even at levels of normal or high sugar, like what I showed you in that problem. This is a very common thing that is underemphasized in our teaching, and we should recognize it, and we should tell the patient that don't worry, you will get better with time, and you don't have to eat at this time. It will pass, okay? This is the set point concept. The same thing I told you occurs in impaired awareness of hypoglycemia. The set point keeps coming lower and lower. So that brings us to the concept of counter-regulatory hormones. After all, the counter-regulatory hormones are what save a person from hypoglycemia, right? So if you look at the counter-regulatory hormones, type 1 diabetes is not a deficiency of insulin. It's a deficiency of insulin and glucagon. It's a bihormonal disease. In fact, that is why, because of the absence of glucagon, that your patients with type 1 diabetics have severe hypoglycemia, and they also do not respond to hypoglycemia well, because they have a deficiency of insulin and glucagon. In 5 years, patients with type 1 have lost their glucagon and more severe hypos. In type 2, the counter-regulatory hormone system is blunted in a decade. In 1 decade, this response is blunted. The older they are, the more autonomic dysfunction they are. Remember, in CKD, the blunted sympathetic response, no renal gluconeogenesis, all these things will predispose to severe hypoglycemia. So remember, the role of the counter-regulatory hormones is as important, and is probably more important than even the thing causing hypoglycemia. So remember this, that the counter-regulatory response is blunted in type 1 in 5 years, in type 2 in a longer time, and in older people. And that is why hypoglycemia can be severe. That brings us to the concept that hypoglycemia and diabetes is not a number. If you read the ADA guidelines, they don't tell you, okay, they say less than 70 is the alert value. Say alert value, and clinically significant is 54, but none of these things in any standard guidelines tell you a number calling hypoglycemia. It's a point at which the person responds with some autonomic dysfunction or a neuroglycopenia and needs help to come out of it. If he needs help to come out of it, that's when you call it as level 3 or severe hypoglycemia, where there is a assistance of somebody else is needed. That's why I told you in the beginning, though we say neuroglycopenia less than 50, it can be less than 30, it can be any number. Remember, it's never a number. It's a number that's probably less than 70. But like I told you, sometimes nocturnal hypoglycemias can occur at 65, 70, like that. And if you don't adjust your night dose of whatever you're giving, you'll produce more and more nocturnal hypoglycemia with a rebound in the morning. So remember this concept that hypoglycemia in diabetes is never a number. Now, coming to the dangers of hypoglycemia, this is common to all diabetics, and this is again standard. You all know all these things like coma conversions, TIA, stroke, etc. And the cardiac arrhythmias and myocardial ischemia are important. I will explain a little later. And then worsening vitreous hemorrhage and accidents, because people will tend to fall, especially the elderly. You don't want any of that to happen. But look at this problem. 45-year-old man travels a long way to his work spot. Every morning he has a big breakfast and he gets up because he gets hungry by lunch. He's gained 6 kgs weight, confesses of being scared of hypoglycemia. Hypoglycemia can be severe. Patients don't want to go through it again. What should be done? This is called defensive eating. So if you find your diabetic patient always gaining weight too much, then you should think that maybe he's eating too much defensively to prevent hypoglycemia, and you should ask him to change his diet and lifestyle. But the more important side effect, the more dangerous side effect is the cardiovascular side effect, which was emphasized by these trials called ACCORD Advance and VADT, which looked at bringing down the sugars to a very low, this thing, 6.4. And these were all in patients who were diabetic for a long duration. They were all old, and they thought that they should bring their sugars down to 6.4, which is the tight control versus 7.5. And what happened in ACCORD, look here, it caused an increased risk of death in the intensive arm. So you brought down the sugars and the patient died. Now, what's the point of all this, right? So this is when we realize that when you have a hypoglycemia, it can trigger off probably cardiac arrhythmias. It can trigger off also plaque rupture, and you can get more cardiovascular problems than you ever anticipated. So that's why the control of sugars should never involve bringing down the sugar so low that you increase your cardiovascular mortality, which is what brought some sanity to the medical profession. And the ADA actually upped its level of HbA1c. Previously, we were targeting 6. Now they say 7 is okay. And that 7 is okay, especially in the elderly. If you have an 80-year-old man, when 8 is okay. All that sense came in after this trial proved that bringing the patients down to hypoglycemia caused more cardiovascular mortality. So whom should we be careful in? The elderly. Too fast reduction is dangerous. Multiple risk factors, repeated hypos with diabetic neuropathy, renal and hepatic failure. These are the people in whom hypoglycemia can be severe and very low. And so that's why you should be careful in them. And this you all know that whom you target a very strict control in a young diabetic who has just begun strict control. In a 20 years into diabetes, old man, less stringent control. If you look at this chart, that's what it tells you. So the elderly, you don't have to go and, control it too much. That's what it says. Okay, let's finish this part of hypoglycemia with a very interesting topic. This is chocolate for your thoughts. 65-year-old man who has been diabetic for more than a decade. He's been on Mixtard every evening. This is one of my own patients. Every evening at 5 p.m., he was sweating, feeling giddy, becoming drowsy. Daughter gave him a chocolate. And he was actually pretty happy because nobody would give him a chocolate otherwise. And he didn't mind at all. So every day he was happy to get a hypoglycemia and take a chocolate from his daughter. And this was going on. And everybody was okay with it until they came and saw. And then I'll tell you, why is this not acceptable? Why can't a diabetic who wants to eat a chocolate, get a little hypo, eat a little chocolate and be happy ever after? Now look at this. Show you one more problem. 70-year-old diabetic is brought with difficult to control blood sugars. Fasting is 50, BP is 325. Look at his A1C, 7. What is the reason? His fasting is 50, his BP is 325, A1C is 7. What is the reason and what should be done? The previous problem and this are linked. If you can give yourself an answer, you give it, and then I will show you the next slide. This is called glycemic variability. This brings us to the concept of what we call as MAGE, mean amplitude of glucose excursions. As you can see, somebody's glucose plummets, then goes up, then comes down, then goes up, then comes down. This is called glycemic variability. And remember, your HbA1c does not reflect the MAGE. It takes an average. So 50 and 325, it averaged itself out, and that's how you got the 7. So if you thought the 7 was fine, you actually missed. This came to us because you found that there was a group of patients in whom there was strict control of diabetes, yet they got complications. Why were they getting complications even with achieving 7? Then you did a CGM on them. You did a continuous glucose monitoring. And then you found out that actually these people were swinging between hyper and hypo all the time. And the HbA1c did not reflect this MAGE. Okay, let's say that it did not reflect. Was it okay? The problem was the people who swung like this, okay, had more endothelial damage, and even if you had 200 all the time, you are better off than somebody swinging between 50 and to 300. So a swing is causing more endothelial damage than a steadily high sugar. Steadily high sugar may have a higher A1C. Okay, you can have 8, but your person who's swinging between 50 and 350 may have 7, falsely giving you, and it may lead you to become complacent. So this concept of MAGE came in because we do not want these swings in blood sugar. That's why the chocolate given to my patient every day by his daughter is not acceptable. And this person whom I showed you, this person whose sugar is swinging is not all right. Because you do not want a MAGE. And if you want to demonstrate a MAGE, you have to do a continuous glucose monitoring, and that will show you. So let's summarize diabetic hypoglycemia. You look for risk factors, usual and unusual, out of which the most important thing, like I said, was the creatinine, and of course, all the other things that I talked to you about. Then we took at the timing of the hypoglycemia and adjust your dose. You recognize the set point concept and think of an impaired autonomic, impaired awareness of hypoglycemia, and you avoid hypoglycemia to restore the functional problem of the autonomic system. You identify the risk groups and decide targets. How much do you want to control? You decide. You know all the dangers of hypoglycemia, and you think of this concept of MAGE, of glycemic variability, which is probably more important than an A1C, right? So these are the concepts that you should know about diabetic hypoglycemia. Now take a breath. We'll go on to the next part, which is non-diabetic hypoglycemia, which all postgraduates will like, because they all think any postgraduate likes a rare condition, right? It doesn't like a common condition at all. And rare conditions come in the exam because you want to stump the candidate or whatever. But the real heroes are those who actually deal with diabetic hypoglycemia and make a big difference. Okay, but that's not attractive, right? So let's go on to the next part, which is non-diabetic hypoglycemia. Like Sanket said, if it's a diabetic with hypoglycemia, you kind of figure out, okay? But remember, there are so many concepts that are built into it, which you should remember and apply. But a non-diabetic hypoglycemia is always a teaser, because you are stuck, you don't know what he's having. How come you keep on asking, are you diabetic? Did you take anything? And he says, no, then you're stuck, right? So let's look at the causes of non-diabetic hypoglycemia. These are a dozen cases which are in our practice. Some I have not seen, many I have seen. So I'll begin with the case that I have seen. 17-year-old boy was brought with on and off tiredness, for which he learned to eat and get better. His parents say that he had behavioral issues and gets aggressive at times. So this boy came to me about 20 years ago with his aggressive behavior, for which he was put on carbamazepine. 3 days before admission, he had convulsions and sugar was low. That's when they realized that he's not faking, or he's not some adolescent bad behavior, but he's actually having a problem. So they gave him dextrose and he got him. So clinical examination was normal. He's non-diabetic, okay, but he's been having some kind of confusions, just misdiagnosed as a psychiatric problem, but now proved to be a hypoglycemia. He's satisfying your Whipple's triad for hypoglycemia because he's got a blood sugar which is low, his symptoms are there, and he became all right with giving sugar. is spontaneous hypoglycemia. Then you keep asking the same things, right? Why the low sugar? Did he eat? Did he fight with his mother? He did not eat the previous day. So ask yourself this question. Can a young boy get a hypoglycemia because he didn't eat? Please remember, no. Nobody gets hypoglycemia because you miss a meal. Nobody gets, because your liver is there full of, glycogen waiting to be, dissolved into glucose and sent into the blood. And then you can attack your lipids and your amino acids. So you're not going to get hypoglycemia just because he did not eat a previous day. So what did we do? We did a fasting sugar. The fasting sugar was 62. We didn't get the symptoms. So we wanted to prove that he has got a hypoglycemia. We did a prolonged fast. And the prolonged fast showed a 72 hours had replication of symptoms. And blood sugar did come down to 50. And we confirmed the hypoglycemia. Okay, now we thought, okay, we got a hypoglycemia, fasting hypoglycemia, extended fast. Think of an insulinoma. Okay. So we did the insulin and fasting sugar simultaneously. Fasting sugar, insulin came as normal. And the sugar was 50. So we are expecting a very high insulin. It came as normal. But please remember, this insulin is disproportionately high. For this sugar, for a 50 sugar, this insulin should have been nil. You can't get a normal insulin. If you're getting a normal insulin for this lower sugar, your insulin is disproportionately high. Should have been shut off at this time. So next we did the C-peptide, that came as high. So now we knew that probably he definitely has insulin coming from his body, because C-peptide is coming from his body, right? So it's an insulinoma. So that's your diagnostic criteria for an insulinoma. So documentation of low sugar, relief after eating, increased insulin, increased C-peptide, increased proinsulin, and no sulfonylurea. We did not have this criteria. Like I told you, in endocrinology, it's always a balance. So for this sugar, that insulin was high. Then we tried to localize the tumor. So we went around looking for the imaging. We did an ultrasound, normal. We did a CT scan, normal. We did an MRI, normal. We should have probably gone for a somatostatin scintigraphy, which we did not have at that time in our institute. So once we knew everything was normal, I remember talking to the surgeon and telling him that we probably think there is an insulinoma, which you're not able to see. And I remember that corridor where we stood and we both thought, he asked me, do you really want me to go in? I said, yeah, probably that's the only way out, because he's been suffering for so long. And the only question he asked me is, are you sure? I said, I probably am sure. I also cannot promise, right? So, but we did. And he was a good surgeon, went in, opened up, intraoperative ultrasound was done. He located a small 1 centimeter tumor in the tail, resected it, and the patient became completely all right. So many times insulinomas are very small. To locate them is difficult, and sometimes intraoperative ultrasound has to be done, or the surgeon has to feel for the tumor and then remove it, right? But of course, many of these investigations need not be negative like happened in our patients. So CT scan can show, MRI can show, and of course, your endoscopic ultrasound can also show. So it shows an insulinoma here. So that's your imaging technique. And finally, you may have to do an exploratory laparotomy to go and see it. Like we said, it's a very rare thing. So I have seen this one case, and maybe I saw two more after that, but they were more typical. But in my 40 years of practice, I've seen only 3. So it's a rare thing. So it can occur at any age. The 90% rule is that most of it is benign, it is solitary, it occurs in intrapancreatic sites, and is very small. The problem is the size of the insulinoma. The lessons we learned in this case are that normal fasting insulin does not rule out. Fasting sugar by fasting insulin is more important, send both simultaneously. And if convinced, open up, because imaging can be doubtful. Okay, look at this problem. Staff nurse comes with hypoglycemia, troubled marriage, suspected to have consumed an overdose of glibenclamide. She denies this. She says, I never took anything. How will you prove that she has probably taken the sulfonylurea? Look at those options there. These are your MCQ options which will come for your whatever exam that you do. So which of these is right? She'll have low C-peptide, low fasting insulin, high C-peptide, high insulin, high fasting insulin, low C-peptide, high C-peptide, low fasting insulin, low pro-insulin. So I hope you got this right. This is a high C-peptide, a high insulin, because sulfonylurea acts through the pancreas. So it releases through the pancreas. So the only way to differentiate an insulinoma from an insulin secretagogue is by detecting the drug. Okay, so in both C-peptide and insulin will be high. Only way you're going to differentiate is to demonstrate the drug in the blood and the urine. And the management of insulin, sulfonylurea-induced hypoglycemia is to give glucose, glucagon, hydrocot, or you can give dextrose. Please remember that sulfonylurea will act for a longer time. The glibenclamide is going to act 24 hours. So you can't just give one dextrose and keep quiet. After 6 hours, hypoglycemia will come back. Remember, the duration of the action of the drug that causes hypoglycemia is the one that decides how long you should give. Okay, and you can give octreotide also is used subcutaneously or IV in patients with sulfonylurea-induced hypoglycemia. Okay, a little complicated chart, but I want you to look at this. This is giving you the non-hypoglycemia, insulinoma, exogenous insulin, sulfonylurea, non-insulin mediated. 5 different categories are there. But I want you to look at only one thing. That is the only column in which you got a high insulin, but you got a low C-peptide. Remember, everywhere else, the C-peptide and the insulin go together. This is high, that is high. This is low, that is low. But only one place where you got a high insulin, but a low C-peptide is exogenous insulin. This is what we call as the insulin C-peptide disconnect. If you have, they are not matching, then you have to think that you gave so much insulin from outside, but very little C-peptide from inside because it's suppressed. Okay, fine. So when you get this disconnect, you have to think that the patient is probably taking exogenous insulin. Okay, look at this problem. 48-year-old non-diabetic man presented with repeated episodes of hypoglycemia. Non-diabetic, repeated episodes, 3 to 4 hours after meals, dizziness, palpitation, everything about hypoglycemia. Reversed by a carbohydrate meal, and sugar is low, so everything is correct. But there is no history of fasting hypoglycemia. It's 3 to 4 hours after a meal. No exposure to insulin or sulfonylurea. So what's the diagnosis here? This is an autoimmune insulin hypoglycemia, which is called Hirata disease, which is common, described by Hirata. It is common in the Japanese. What is this? This is a hyperinsulinemia, hypoglycemia, because of antibodies to insulin being there. And there's no prior, not that you gave insulin and you produced antibodies, not like that. And there are no pathological abnormalities. So what's the mechanism of this is that the insulin that is there binds to antibodies and it stays there. So the insulin that's produced also stays in one corner. Let's imagine as the glucose level falls, endogenous insulin release increases. So what is bound to the antibodies keeps on getting released after a period of time. That's why you get postprandial. After the insulin has gone up, bound to the antibody, sitting in a corner, and then slowly comes out. And that causes hypoglycemia. So there are cases which are published. That's what I put up here. And there is also a case series if you want insulin autoimmune syndrome and an insulinoma. You know that the insulin autoimmune syndrome is postprandial, whereas insulinoma is fasting hypoglycemia. This is associated with, remember, this is an autoimmune syndrome. So it has got several other autoimmune connections, whereas this is more of men. Multiple endocrine neoplasia, insulinoma is one of the features. Prior exposure to drugs. Now, this is what you should look for whenever you have a person with autoimmune syndrome. You look for methimazole, carbimazole. These are some of the drugs, and even a proton pump inhibitor and precipitate autoantibodies. And then these autoantibodies can actually and if you look at the insulin levels here, it's very high. Serum insulin levels are very high in an IAS, whereas it's moderately elevated in insulinoma. This I will explain to you in a minute. What is this ratio? And of course, this is showing abdominal imaging is showing an insulinoma. But please remember, this is fasting hypoglycemia. This is postprandial. This is related to autoimmunity, probably triggered by a drug, and then can be related to other autoimmune conditions with associated very high levels of insulin. that is called Hirata's disease. Now, I talked to you about the insulin C-peptide ratio. What is this insulin C-peptide ratio? Normally, the ratio is less than 1. Though you have for every C-peptide 1 insulin, both are released simultaneously, right? So you should have a ratio of 1. Why are you not having a ratio of 1? Because your insulin lasts only 5 minutes. C-peptide lasts longer. There's always more C-peptide than insulin in the blood. So your ratio is always less than 1. There are only 2 conditions where you get an insulin C-peptide ratio of more than 1. And that is, one is autoimmune hypoglycemia, the other one is exogenous insulin. That's the importance of this ratio, that only 2 conditions cause an insulin C-peptide ratio of more than 1, and that is autoimmune hypoglycemia and exogenous insulin. So like I said, postprandial can be fasting, recurrent, self-limiting. If you identify what is the drug that is causing the problem, then you can remove the drug. It is self-limiting, and this will go when the drug trigger is withdrawn. That's the importance of seeing this. More common in Japanese, but has been described in Indians also. What's the treatment of the IAS? Small frequent meals, give carbohydrates. Acarbose can be given to delay the carbohydrate absorption so that it doesn't go up suddenly. And of course, to beat the autoimmunity, you can try everything. Steroid, plasmapheresis, rituximab, all these can be tried. And of course, in very bad cases, you can give octreotide or a partial pancreatectomy. But generally, if you identify the drug trigger and remove it, most people get better. Now look at the next case. 50-year-old non-diabetic man has fever for 3 days and is given some drugs. Then he comes with hypoglycemia. He's not a diabetic. Which drugs do you think could have caused? Some of the common causes are like quinine. Of course, we don't use much quinine now, but the ciprofloxacin and the gatifloxacin, they can all cause hypoglycemia. But if you look at the drugs, apart from your insulin sulfonylureas, you have the fluoroquinolone, the sulfonamides. Many times I've seen patients, especially elderly, given one Bactrim DS for something, some UTA or something, then they come with hypoglycemia because the moiety looks the same and it gets displaced from the protein binding of the sulfonylurea. So that's why sulfonamides can cause. Hydroxychloroquine is very well known to cause. Pentamidine, salicylates, lithium beta blockers, and alcohol, which we will talk about a little later. Okay, look at the next case. 54-year-old nurse with a long-standing history of obesity. She undergoes a Roux-en-Y bypass because she wants to lose weight, and then surgery, post-operative, she loses a lot of weight. After 5 years after surgery, she begins to develop hypoglycemia. So within 1 to 2 hours after eating, she gets all this confusion, palpitation. She eats carbohydrates and feels better. So what is she having? Post-bariatric surgery, postprandial hypoglycemia. So hypoglycemia is very well known to occur post-gastric or bypass surgery or post-bariatric surgery. So these patients are warned that they may get hypoglycemia. Why is this happening? Many causes. So suddenly you're dumping all the glucose right into the intestine in a hurry. It triggers off the release of insulin and incretins, and all of them together can cause very bad hypoglycemia. But there are many other explanations which I cannot really explain here. But remember that post-bariatric surgery, several factors will contribute to hypoglycemia because of the abnormal anatomical pathway. This is a person I used to deal with in my practice, a 40-year-old man who had a gastric ulcer, and he was operated years ago. 20 years ago, he was operated. Post-surgery, he started feeling, actually of late, weak, tired, 3 hours, and after eating ice cream, whenever he ate ice cream, sugar would go down. Now, what is happening here? It's called late dumping. So many times this late dumping happens post-surgery when you do a gastrectomy. Postprandial hyperinsulinemia, especially when you take fast-acting carbohydrates, like whenever he took ice cream is when he went into bad hypoglycemia later on. So late dumping can occur. And again, here what you have to do, small meals, you have to give acarbose, octreotide, etc. So this is different from bariatric surgery, but just a late dumping can occur after gastrectomy. So all these people must be educated on how to manage their hypoglycemia. So if you look at the difference, there are 2 causes of postprandial hypoglycemia. One is this IAS, that is the autoimmune syndrome, and the late dumping. Okay. Now, if you look at it, most of it will be the same. All of them are the same. But in IAS, there's an offending drug. Here, there is nothing. Here, there is and a high carbohydrate intake may be there in both. This shock, near syncope, and all features of late dumping. They are not features of IAS. Insulin antibodies are present here. They are not present here. Here, of course, there's a surgery done. Okay. So the context-wise, they are very different, but both of them are causes of postprandial hypoglycemia. There's also an entity which has been vaguely described as idiopathic postprandial hypoglycemia, where 2 to 5 hours after eating, because of the slow initial phase of insulin and a rebound phase later, some people get hypoglycemia 2 to 5 hours after, and it's supposed to be a marker of pre-diabetes, but generally, if the patient takes small feeds frequently, we can avoid this, what we call as idiopathic postprandial hypoglycemia. Now, let's go on to some other cases. 40-year-old cirrhotic develops an infection, goes into hepatic encephalopathy. You're always worried, right? When you have a hepatic encephalopathy going into hypoglycemia, you're really stuck because you know that there are no glycogen stores, liver decreased uptake of insulin by the liver, and infection. All of them can cause hypoglycemia. So prognosis of a cirrhotic with hypoglycemia is always bad. Similarly, if you have an acute viral hepatitis also, altered sensorium, this person is going into an acute liver cell failure. This prognosis is really bad because again, it shows the liver is empty of glycogen. In the ICU, many times you find patients like this, necrotizing fasciitis, septic shock, AKI, and then the ICU staff says he's not looking all right and does a blood sugar is low. Many times it's very important to observe your ICU patients, especially when they are lying down like that. Nobody looks at them, they may be in hypo. Now, what causes hypo? Liver failure, renal failure, and sepsis, all three together. The three main factors which can cause hypoglycemia are all there in him, and that's why. So that's why it's very, very important that, especially if your patient is sedated and comatose, finished, then nobody will know he's in hypo at all. And that's why they said the nice sugar study put up these guidelines that you better keep the glucose between 140 and 180 and don't aim for the 110 glucose, because a 110 glucose will always cause a problem. You may tilt the balance and go into hypoglycemia, and a sedated patient, nobody knows, he can't even complain. And hypoglycemia as such in sepsis is a poor prognosis and causes a higher mortality and morbidity. Now look at this problem. 45-year-old non-diabetic man went on a drinking spree one night when he got a raise in his office. So past 1 week, he was working very hard on a project, irregularly taking meals, and then he has been consuming alcohol. Even otherwise, he was malnourished. And then he got very happy when he got a raise and binged. Next morning, he is unconscious. What's the mechanism of this? The mechanism of alcohol-induced hypoglycemia is slightly different. One is there is increased insulin secretion because of the empty calories that go in with the alcohol. It does not prevent glycogenolysis. That's why you don't get an immediate hypoglycemia. Nobody who drinks gets immediately hypoglycemia. No, it's late because the liver and the glycogen save you for the immediate part. It's only late that you have a problem. So late on, so that's why this man was found the next morning, right? And counter-regulatory hormone response may be blunted. So the point is, if you are already malnourished and you are not eating properly, your tendency to get hypoglycemia, and you cannot protect yourself by you keep on drinking alcohol, and you have a long fast, then your tendency to get alcohol-induced hypoglycemia is pretty high. Okay, another interesting problem. 65-year-old man presents weight loss, loss of appetite of 6 months duration, comes with persistent hypoglycemia needing dextrose drips, is very emaciated. And you see one more clue there, that's the lactate levels. They are 30, okay, very high. So you got a hypoglycemia, lactate, and the BP is normal. You all know why I have said the BP is normal, right? You have to find out what type of lactic acidosis is it. Okay, so if your BP is normal, it's not a type A lactic acidosis, it has to be type B. So it's a type B lactic acidosis in malignancy, which is called the Warburg effect. Okay, I have seen 2 patients presenting with this. So this is called the Warburg effect, where the cancer cells, they go into an anaerobic metabolism and they go into the conversion of glucose to lactose fermentation. And this anaerobic glycolysis was described by this person called Warburg, who received the Nobel Prize in 1931. And this glucose hunger of the cancer cells is what you are using in your PET scanning. So this Warburg effect has a combination of hypoglycemia persistent and lactic acidosis. So when you see this combination, you have to think whether there is a malignancy there. There are the other causes of this combination, hypoglycemia and hyperlactatemia, is paracetamol-induced acute liver failure, severe malaria, lymphoma, or glucose 6-phosphate deficiency. So there are only few causes of this combination. So when you see the lactate with a normal BP, which is a type B lactic acidosis, is a big giveaway. Once you get that, then you have to think there are very few causes which are causing them. One of them is a malignancy, which is called Warburg effect. For some reason, the lactate there prevents the person from going into coma. So even if you have a very low sugar, your patient is still conscious. One of the things you have to remember is that the lactate probably is utilized by the brain to remain conscious. So your patient is still conscious. Even with a very low sugar, he's still conscious. You have to think maybe because of the lactate being there. Okay, one more problem. 70-year-old diabetic man comes with breathlessness of 3 months duration. He feels weak and tired. In the ER, his sugar is 45. That is his chest X-ray. So chest X-ray is a big giveaway, right? So what's the diagnosis here? I'm just giving you your 5 seconds to make your diagnosis. With that chest X-ray and hypoglycemia, what do you think of? That's a non-islet cell hypoglycemia. And that non-islet cell hypoglycemia is all these causes. The commonest being hepatocellular carcinoma, mesothelioma, and then you got many things. What I showed you is a mediastinal tumor, because you saw the mediastinal widening. Now, what is the mechanism of this non-islet cell hypoglycemia? It's like insulin-like growth factor, IGF-1 and 2, which are produced by this non-islet cell tumor, which is causing hypoglycemia. So remember that several other malignancies can cause hypoglycemia because they produce insulin-like growth factor. The insulin levels in them will not be high, showing you that it's not coming from, now the C-peptide will be high, showing you it's not coming from the pancreas, coming from a non-islet cell tumor, and many of these people can have a hypoglycemia, right? Okay, look at this. The lab calls you up and warns you that the 30-year-old patient has a blood sugar value of 35. He is sitting in front of you, fully conscious, well-oriented. He came for a fever of 3 days duration. So you are surprised, he's surprised. He is not in any way looking to you like hypoglycemia. What are your possibilities? That is artifactual. That means a lab error. Now, when do you get this? You get this because if you keep your blood sugar, that container, your tube for a long time and send it late, cells in the container can eat up the glucose, and this will happen when there are a lot of cells, like in a leukemia, hemolytic anemia, polycythemia. The patient I projected was one of my patients who had not fever. He actually had a polycythemia. His blood sugar alert value came to me and he was fine. And then we knew that he had a polycythemia. So you must remember that if you delay your transport for the blood sugar, it takes a while, then the cells in the tube can simply consume the glucose and you get a falsely low blood sugar value, which is what you call as artifactual hypoglycemia. This was published in the Lancet 2014. I don't know whether you are aware. I mean, you may not have been in medicine. I'm not sure. 2014, there's a lot of children who died in Muzaffarpur with acute toxic encephalopathy, and they were actually labeled as some other disease. Ultimately, they were found that they were all eating this lychee fruit. The children were hungry and they were malnourished and they were eating this lychee fruit, which was causing hypoglycemia. So consumption of certain fruits also can cause it. This fruit has a particular substance which causes hypoglycemia, and children actually died because of that. And this was completely avoided once the science went in and it was found that the children were, this fruit also grows in those areas and children are very fond of it, etc. So on an empty stomach, they should never eat the fruit. Once the education went in, a lot of children were saved. So I'm not discussing the common things like Addison's, hypopituitarism, hypothyroidism. I just made a passing mention, and cardiac failure, liver failure, renal failure, which I also said. Okay. Now, just 2 minutes about the treatment of hypoglycemia. Can a person recover from hypoglycemia without eating? Yes, he can. And otherwise, this is all what you know. You have to give a snack or this thing if somebody is conscious. Otherwise, you put him on a dextrose drip. You can also give a glucagon. And please remember that this should be continued for the duration of the action of the drug that you have given. So that continuation treatment is important. And for sulfonylurea-induced hypoglycemia, octreotide can be given. Okay, fine. Now, so we described an insulinoma in a 17-year-old boy. We talked about the Hirata's disease. We talked about the insulin and factitious hypoglycemia. We talked about post-GI surgery and dumping, drugs and alcohol. We talked about sepsis, endocrine disorders, Warburg effect malignancy, non-islet cell tumor, and artifactual. These are the 10 cases that we have described. So we finished the diabetic hypoglycemia and the non-diabetic hypoglycemia. This is rare, except in some conditions like sepsis, etc. Most of the other things are rare. But I think that should be the approach to hypoglycemia. First thing, whether it's diabetic or not. And if it's not diabetic, run through this list. Thank you very much.
Yes, ma'am. It was wonderful class.
Thank
If
you.
anyone has any doubt, please feel free to message, or you can text me on WhatsApp also, I can convey. One question I got: in a patient who has persistently high sugar, can, if patient is symptomatic at blood glucose level of 100 or 120, should we think it as a hypoglycemia, or how should we approach this kind of patient?
If the blood sugar is 120, what happens now? Say that again.
Yeah, so if patient has a persistently high sugar, and in those kind of patient, if there are symptom of hypoglycemia and then the glucometer shows around level of 100 and all, so how to approach this kind of patient?
Right. See, at a sugar of 100 or 120, you're not going to get any diabetic complication, right? You are bringing down the sugar to acceptable levels. If the patient is getting symptoms at that level, it may be, like I said, the set point change when you got from the high this thing to a lower sugar. At that point only the body, the autonomic system is reacting to it. Over a period of time, the set point will set itself right, and you will not get that problem. You can ask the patient to eat something, but tell him that please don't think that your sugar is very low. Don't have to eat, a plain sugar. You can have a complex meal to avoid the symptoms.
Yeah, okay. Then there is question, I think it's still I felt patient with persistent high sugar only after dialysis. I'm not sure whether the question is still complete or not, but that's what I could see in chat.
Now, dialysis actually works in many ways. One is because it removes the uremic toxins. Actually, patients tend to improve their diabetic control after the dialysis. But when you dialyze without, without a solution which has glucose on this side, you may go into hypoglycemia. That's what I remember in Manipal, we used to give on 50% dextrose after dialysis because these patients would go into hypoglycemia just after dialysis. And to some extent, to prevent dialysis disequilibrium also, we used to give that.
Yes.
But otherwise, there's nothing much. If you have a dialysis solution with glucose on one side, then you shouldn't have a problem on the other side.
Okay, then there is a question: how to prevent nocturnal hypoglycemia, specifically in patient with hypoglycemia unawareness?
That's a very good question. That's a very important question, because deaths can occur, especially in the elderly, because of nocturnal hypoglycemia. The most important thing is that you do a 3 a.m. sugar. Okay. If you have we generally do what we call as the 8-point sugar, right? When we admit the patient and we think there is hypoglycemia, you do a fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and then you do a 3 a.m. The 3 a.m. is the one that tells you about nocturnal hypoglycemia. Many times people don't understand. Actually, your dinner, you can have a dinner maybe at say 8 or 9, but you just have a glass of milk at around 10, 10:30, like that. That gives you the extra cover there to prevent the nocturnal hypoglycemia. And your night insulin or whatever sulfonylurea that you're taking, it need not be very high. If it is very high, it can dip, and the dip can cause hypoglycemia, and there can be a rebound with the fasting sugar being high the next morning. So the simple tips that we tell patients are that you break your dinner into 3/4 as dinner, 1/4 as a post-dinner snack, or something like that at around 10 o'clock, so that you allow that sugar to be taken care of, because you may be giving an insulin. For example, you may be giving a pre-mixed insulin in the night, say 10 units of mixed RD you're giving. If you're giving it, it's going to peak sometime. And that peak may come at 3 or 4 o'clock. So that's why you're worried, especially the short-acting component may peak. So that's why you tell them to have a post-dinner snack and adjust and document your hypoglycemia, but at least once when you're getting the symptoms, to do a 3 a.m. sugar. Even if you don't get the symptoms, one day put the alarm and do a 3 a.m. sugar, which is what we do in the hospital.
Okay, ma'am. Great. Thank you for your time, ma'am. It was amazing presentation.
Thank you all
Yes,
for
yes.
patient listening.
Sure.
So many postgraduates at this time, I don't know. Thank you.
We can learn, ma'am. You are teaching. That's a blessing for us. Thank you.
Okay.
Thank you, ma'am.
Thank you very much. Bye-bye.
Yes.